In this lecture, I would like to do four things. First of all, I would like to look at some background considerations related to this topic of remote monitoring. In that, there are four things I would like to address with this background, starting off with some demographic trends. As you all know, if we look across the planet, that we have a demographic time bomb. People are aging, and that is going to continue as a trend. We also know, commensurate with that, that heart failure prevalence and AF prevalence are both increasing substantially. We also know, in addition to this, with CID and remote monitoring trends, that there are changes. We have devices that are therapeutic. We also have devices that are purely diagnostic. And together, that gives us more information about managing patients. In addition to those devices that are implanted, we also have a plethora of wearable devices that are continuing to grow and continuing to improve. And they're developing in all different modalities, some of which are unusual in that they can also be worn in regular garments and tell us whether we might be at risk for or be having arrhythmias such as atrial fibrillation. Now, when COVID came along, remote monitoring picked up substantially across the globe, as you can see on the left slide there. And then in terms of making it work, it actually was very easy. People really accepted it, and there were very minimal problems in getting it operative and getting it going. We also see, in terms of this market for devices that imply CIEDs, implantable monitors, and wearable monitors, the market is growing substantially, and it is continuing to grow and expected to grow to a phenomenal level. And if we look at that economically, you can see that by 2031, about $117 billion will be spent on remote monitoring. And that's growing at almost 14% per annum. That is an incredibly large growth based on all these types of devices. So the third thing in this background I'd like to address is, what do the guidelines tell us about what we should do with remote monitoring? Well, as you can see here from the recent updated consensus statement, that in patients who have an implantable device, remote monitoring is recommended as a standard part of the routine care of said patients. And what you see here is that the time to review was substantially improved. Instead of waiting for a long period of time, instantaneously or almost instantaneously, review of these devices and the data stored therein became available. However, it's not all perfect. As you can see here, when we look at it in terms of mortality and we look at hospitalization, in this earlier study using remote monitoring, we still had a way to go. We thought there would be benefit, but there truly wasn't. There was some total cost reduction, as you can see over there on the right, probably at least in this study related to decreasing hospitalization or decreasing visits among physicians and other clinicians. My last consideration in this background topic is to look at where we are in clinician supply across the global market. Supply and demand are operative everywhere, not just in economics, but in people power as well. We know that demand and supply can oftentimes be in one direction, or they can be in the other direction. Right now, we have the need for more clinicians to read these remote monitors than we have a supply thereof. So we've got to figure out how to make this more effective and more beneficial. And that's what I'd like to concentrate on. And as you can see here, whether you look at physicians, whether you look at nurses and APPs, or whether you look at device technicians, the shortage is substantial everywhere. And it's not just in one geography, it's across the entire planet. Now, the Fitbit study was an important study, and I put together a little bit of an analysis on that. If you look at the percentage of people who had an abnormality and you looked at their recommendation for office visits, you will see that in the United States, we would need to add today almost 1,000 new clinicians just to provide one office visit. And across the planet, we would need to add 2 million clinicians just to provide that visit. This is not possible, nor is it sustainable. So we have to think differently with how we do it. Otherwise, there will be substantial breakdown and substantial concern on the part of patients and the part of clinicians. So concerning the background, I would say at this time, we have substantial demographic changes. We have significant growth in implantable and wearable devices. The guidelines support and encourage and actually require remote monitoring, but we have a supply-demand problem in terms of available clinicians. So how do we get to the next level? Well, an American CEO, Jack Welch, who is from my hometown of Boston, said, "Willingness to change is a strength, even if it means plunging into total confusion for a while." We may be in a state of confusion, but I hope to bring us out of that. So what might be the solution? What is it? Let's look forward. and see if we can come up with some ideas. So these are some options for improving or optimizing arrhythmia treatment. I want to present 3 of them to you. Let me look at the first one. Third-party vendors. Those are outside organizations that help us facilitate the attainment of these devices and the information stored within. Now, they are growing across Europe, they're growing across North America, and I don't know if they're growing in Asia, but even if they're not, institutions are going to have to do the same thing. And those are some of the vendors that are there. And the guidelines in the recent consensus statement say that they should be considered as an option to help facilitate obtaining information about those patients. Now, what happens is if you have someone getting all these tracings, they get sent up to the cloud and then sent down to an overworked clinician who has to figure out what to do with each of those tracings. And that can be problematic. This is an example of one we got here, and as you can see, 125 pages. Multiply that by 15 or 20 and put it at the end of your day's work, and you will find out that it is very vexing and problematic. Now, if all these vendors do is give us more information, more devices, that 125 pages times 10 becomes 125 times 20 or 30 or 40. More information, but not enough time to assess it. So how might we do this better? Well, I would like us to look at how we approach this. This is something that I would call non-actionable. A patient with permanent atrial fibrillation whose rate is controlled. Nothing that we need to do. Over here, I would call these actionable. Frequent runs of non-sustained VT or ventricular fibrillation episode during sleep that shocked the patient, but actually the patient didn't get woken up or know about it. Or lead noise that will require perhaps an extraction or modification, or atrial fibrillation and the patient is minimally symptomatic, but the rate is elevated and we want to avoid a tachycardia-mediated cardiomyopathy or other problems. These we don't need to do anything about. These we do. How do we break them out and how do we look at them? Well, I put together this slide looking at atrial fibrillation and what components should be looked at in all devices, what lead problems should be looked at in all devices, and what heart failure components should be looked at in all devices. Now, for certain different devices like CRT devices alone, we have to be concerned about the percentage of biventricular pacing, and for defibrillators, therapeutic interventions. And in fact, in this particular study, as you can see from Aileen Ferrick, she looked at the alerts, and red was where you need to do something semi-emergently, either that day or the next day, ideally. Yellow is elective. You can do that in a couple of weeks or maybe a month, depending on what it is. There's no emergency. So these we got to work now, these we can wait. So let's look at how this plays out over time. This is a study that looked at how many of these alerts actually require our attention right away. And as you can see, it was only about 2%. So out of all the transmissions that came in, a clinician really only needed to interact on 2%. Others, a 14%, required some intervention over the next 2 to 4 weeks, but 84 of them did not require any intervention at all. So we're spending a lot of time doing redundant work that doesn't add value if we're doing that, which was most of the transmissions. This is another study which showed that actionable events were, again, very low. Instead of 2%, it was almost 5%. But again, very, very low across the board. We looked at this and put in a program at our institution, and we reduced red alerts, that is those you need to do something about, by almost 50%, and yellow by 23%, moving that into the other bucket where you don't need to do anything at all, freeing up clinician time to do more productive work. So again, this is the classic way in which transmissions occur. And what I think we have initially done, we had non-continuous monitoring, where the patient had to contact the office, they had to do something and intervene. Then we had continuous, which is where we are now, but we need to move to alert-based only. So all we are doing is dealing with things that require attention. We're going to have to rely on AI to get us where we need to be. So we can filter down and we only get a small amount. It'll make our job better and provide better care for patients. What about artificial intelligence? That's another way with remote monitoring that we can move in the right direction. So AI is important. Here is an AI colleague saying, I will improve your remote monitoring. Well, how could that work? These are false abnormalities for atrial fibrillation due to rate irregularity in an algorithm, baseline artifact, or far-field R-wave oversensing, all of which are not atrial fibrillation. Down below, we have periods where you could undersense atrial fibrillation, and then we have with an implantable monitor, false positive bradycardia due to a variation in gain. Those are all things that are problematic. Those are all things that do require attention of clinicians, but if AI can make those better, we don't have to worry about it. And this is, in fact, when implantable monitors first came out, and you see that the false positives outweighed the true positives. So we were dealing with noise rather than signal in the vast majority of cases. Now, what happened is that we are continuing to improve. This is a study from Sunit Patel in New Jersey in the United States. And as you can see here, they did not change the true positive rate, but by improving the algorithms, they could get rid of many of the false positives. And that's what we need to do with AI, make the programs better. We can also learn from some of our other colleagues. This is a group using assessing blood pressure, and another one for HFrEF, getting on guideline-directed therapy, using a protocol with a monitor external device to remind your patients to take their medicines, to remind them to record their blood pressure, to give prompts to up the medicines if needed, et cetera, et cetera. So a lot of these things can be done semi-automatically or automatically to make it better for patient care and less taxing on clinicians as a whole. And I think that's, again, where AI can help us. This is one in our field of electrophysiology where that was beneficial. These are patients who had an ablation, and as you can see here, they were given a monitor, an external monitor. And if there was no alert, no problem, nothing to do. Sometimes if they were significantly problematic, they would be sent to the emergency department. Conversely, if there was a problem, but it wasn't substantial, then they would probably schedule outpatient evaluation and treatment as warranted by the case. And as you can see, most of these were green. That means that they were sinus rhythm and nothing needed to be done. Patients were reassured, clinicians didn't have to spend time looking at it, so all was well with the world. And in fact, they reduced by this app compared to conventional monitoring using Holters or getting EKGs in the office. They reduced ER visits and unscheduled outpatient visits substantially to a significant degree. So when I look at AI as a partner here in remote monitoring, I think we should listen to the words of Jag Singh, who said, "It is time for us to get artificially intelligent. That way we can move in the right direction." Integrated clinics are also important. As you can see here, there is a trend from the pure physician clinic to using APPs, nurses, dietitians, and others to help manage patients. And you can see that this trend is growing, and I suspect it will continue to trend. The physician should be providing direction, but doesn't need to be interacting on every single encounter with patients. And if we look at the data here by, for example, a nurse-led clinic here, looking at cardiovascular death and hospitalizations according to specific guidelines, there was really no difference across the board. But if you looked at the experienced centers versus the less experienced centers, there was benefit. So it's not just putting a nurse or a dietitian or an APP in a clinic and letting them go about on their own. It's putting together a program that is based on the guidelines, that is effective, and that delivers promptly and appropriately. And in fact, the impact of integrated care is significant. We look at all-cause mortality, if we look at hospital admissions that are cardiovascular in nature, and if we look at AFib-related hospital admissions, you can see in the first two it was statistically significant. In the latter, there was a trend, though statistical significance was not met. And I view, therefore, the future clinic is going to be not that people need to be seen every 3 months or every 6 months or every year, but unless there's a problem where the remote says that this needs to be dealt with, maybe they only need to be seen once every couple of years, as long as they're clinically stable. Less visits, more use of AI, more use of remote monitoring, and better care for the patient and less problems with the clinician. This is New York City. Change is necessary now. This is in 1900 and 1913. At this time, there was one, what they called horseless carriage or car, and then 13 years later, here's one horse-driven carriage. We've got to look at it that way. We've got to change. We've got to change effectively. We've got to have open minds. So in terms of arrhythmia options, let me give you my summary thoughts. First of all, I think there can be real improvement from third-party payers, and they need to move towards effective, actionable alert programs. We only deal with things that require it. We need to have good AI partners and good AI algorithms to improve the quality of the devices that we're assessing remotely. And we need to put all this together into an integrated, team-based, guideline-directed clinic approach. I will quote here Van Gogh, who said, "Great things are done by a series of small things brought together." We need to work carefully, cautiously, consistently, and together to get where we need to be. I like to talk about heart failure optimization options next. That's not my area of expertise as an electrophysiologist, but we deal regularly with our heart failure docs. And there are two approaches, pressure-based and algorithm-based devices. Let's look first at the pressure-based devices. I think most of you are familiar with the CardioMIMS data. This is trends and tracings here. And what you see is that in Monitor AF and then in this meta-analysis, that there was a benefit in terms of outcomes by using these devices in appropriately defined patients. In addition to that, there are algorithm devices in pacemakers, in CRT devices, in defibrillators, et cetera. These are some from the different manufacturers using a variety of different components. I'm not going to spend time describing how they're built, but they're built to a moderately effective manner. But what you see here is they can also tell us 30 days beforehand, based on information, that the patient is likely to have a heart failure event, need to go to the hospital, the clinic, or something such as that. So that's what needs to be done. These devices can tell us that. However, if we look at it in this particular study, you can see that there was no difference in terms of mortality or CV hospitalization, despite having this ability with devices to do this. And why is that? I think the reason is demonstrated here. Alerts came through, the patient was only contacted a little more than half the time, medical intervention was taken only about a third of the time, and medication changes only about a quarter of the time. So if we don't put effective programs together, even though we have this technology, we're not using it and we're not going to get to where we need to be. So this summary, I think, on heart failure meta-analysis really tells us where we are. Yes, it does help decrease mortality. Yes, it does help decrease heart failure hospitalization. But it is not because of the technology that's invasive in either of those cases. It's because of taking this invasive technology and putting it in the hands of clinicians who can make a judgment about where to go. And that was true for mortality and equally true for heart failure hospitalization. So it's the technology linked to a clinical event. So in terms of summary here, I would say there is a potential role for pressure monitors. And there's also a creation of effective algorithms with these devices that can help us move effectively in the right direction. I will quote our former president, Barack Obama, who said, "Change will not come if we wait for some other person or some other time. We together are the change that we seek. We must drive this forward if we're going to be effective." I'll close with my final thoughts in the next minute. If we're going to do this, we've got to communicate with all of the stakeholders. These are our cardiovascular physicians in other specialties. They need to know what we're doing and how we're doing it so they're not confused. Similarly, there are other physicians like hospitalists, general practitioners, APPs, ER doctors. They need to know how all this works so that they understand and they buy in and we're working together. We also need to communicate to the patients. Some patients expect you to be calling them every day because they've got a monitor. They need to know we're only going to get in touch with you if it tells us that something needs to be done. That needs to be effectively and earnestly communicated to patients. So here are my summary thoughts right here. Number one, in terms of operational concerns, we have a demographic difficulty with an aging population with more disease. We have substantial growth in implantable and wearable monitors. We have guidelines that tell us we should be using remote monitoring more, but we have clinician supply problems. Two, I believe we can optimize management arrhythmically by looking at third-party vendors and AI programs, and those third-party vendors can be internal programs as well, but we need to be innovative, they need to be team-based, and we need to be thinking differently. Otherwise, we won't get to where we need to be. The same thing applies for heart failure that applies for arrhythmias. We can do pressure-based monitoring and algorithm-based monitoring effectively if we put good programs in place. And most importantly, when we make these changes, like I said, we need to communicate to clinicians and to patients. So Steve Jobs was a very important innovator. We have many things that he and his colleagues invented. I bet you all could hold one up right now and we'll see it. So what he said one time was innovation distinguishes between a leader and a follower. I think we need to lead, not follow. So I thank you very much for your time. It's been an honor to be here, and we'll go from there. Thank you.